Good morning. Welcome to today's session, Can We Cure Medical Debt? My name is Alan Weil. I'm Senior Vice President for Public Policy at AARP. I'm pleased to lead a discussion with three experts on the subject who come at it from a variety of perspectives, which you'll gain the benefit of shortly. Of course, medical debt is a uniquely American phenomenon. We don't just have the most expensive healthcare system in the world, we also structure our system around high levels of patient cost sharing, which is the source of so much debt. And unfortunately, although, of course, people with health insurance are less likely to incur debt than those who have to pay on their own, still, debt is a phenomenon regardless of whether you're uninsured or you have insurance. Government programs like Medicaid have very limited cost sharing, but even Medicare, which is universal, leaves significant financial obligations to patients who need care. So this is a topic that touches Americans in a not particularly great way. And we're going to talk about the scale of the problem and some approaches to trying to reduce it as a problem. I have, as I mentioned, a terrific panel, and I'll introduce them and then ask them each a question to kick us off. So Manasa Kona is at Georgetown and does research on this topic, and will tell you a little bit about her work. Jared Walker is the founder of $4. I had Jared on my podcast when I was at Health Affairs, and he is really an expert in charity care, which is something that not a lot of people understand that well. And we have State Representative Naquetta Ricks from Aurora, Colorado, and Colorado is a leading state in addressing this topic. So you're going to get some great insight in this session. Let me start, Manasa, with you. If you could just sort of set the stage. This is an area of focus for you. Yep. What do we know about medical debt in the United States?
Yeah, absolutely. So medical debt is exactly what it sounds like. It's unpaid medical bills. It can manifest in a couple of different ways. So there's money that you owe to the hospital itself. There's money that the hospital then assigns to a debt collector. There is money that you owe to a credit card because that's how you paid for the medical bill. There's money that you might owe to your friends or family that you borrowed from to pay for your medical bills. So medical debt comes in a lot of different forms. And the estimates obviously vary because there's different methodologies involved. But I think one of the estimates that we've seen says it's about 40 million Americans are in medical debt, and the scale of the problem is about $220 billion, according to certain estimates. Of course, it's depends on how you slice and dice the population and where this money is held, but that's a good sort of scale to keep in mind. And so what happens when you have medical debt, right? So you've got the hospital. This is kind of a process that varies hospital by hospital to some degree. So they can collect in-house, and they reach out to you and they ask you multiple times. Then they say that they're gonna put this on your credit report that you have not paid for a medical bill. Your credit report tanks. They can say that, hey, we're going to sue you. We're going to try to, take directly from your paychecks or take your home, and try to get people to pay that way. Or the hospitals can directly sue people in court to, garnish their wages or to, foreclose on people's homes and to basically get paid on these unpaid bills. But a lot of the times we're seeing that hospitals are contract away a lot of their billing and collections processes over to third parties. So we see an emergence of entities like revenue cycle management companies that are, generally speaking, for-profit companies that basically say, hey, I know billing's gotten really complex for you. Let us take care of it for you. And all you have to do is hand over your bills to us and you will get your revenue. No questions asked, right? It's what are you really doing in that company? Good question. We don't really know. This is a relatively unregulated entity. So then we've got those entities. Then a lot of hospitals will sell debt. You've heard stories of medical debt forgiveness where debt is sold to local and county governments or to undue medical debt that buy it and then forgive the debt. But then they also do sell it to people as portfolios for people to collect on. So, they'll have thousands of debt cases. It's basically an assembly line in the court. You show up, you kind of, file these cases. The people don't even know that this is happening for the most part. They're not showing up. It all goes into default. So the judge is like basically as an assembly line, granting these people like garnishments and whatever, these judgments. And the amount is snowballing. So a lot of the medical debt bills tend to be of smaller dollar bills usually, but then by the time it gets to the end of this process after years and without any caps on interest rates, the amount has now ballooned. And it keeps ballooning. Post-judgment interest rates are fairly high in a lot of states. So really, like, there's a lot of negative downstream effects of what happens once you have a bill that you're not paying. There's been evidence that people forego basic necessities. They don't go for follow-up health care. Obviously, the mental stress is self-evident from all of this. Is a huge issue. So it really does impact people's health as well, in the long run. So it's a really insidious problem with a lot of different actors, kind of involved. And I don't think that we necessarily have the clearest picture of what's going on. And I think that's kind of what my research tries to unpack.
Well, with that evidence base, I want to turn, Niquetta, to you. You are a state legislator. You must hear about this from your constituents. What do they say? What's their experience?
And thank you, Alan. Yes, absolutely. So in Colorado, there's over 700,000 people who are impacted by medical debt. And in the case of a regulation that we passed in 2023, this bill came about because of so many complaints from consumers and people within our constituency talking about medical debt. Medical debt is something that you don't typically that you don't want to incur. It's not like you're going to go buy something, but it happens because maybe someone gets cancer or maybe they're in a car accident, but they need to be treated. And so this debt can impact people in so many different ways. Getting a student loan, getting a car loan, going to school. In one instance, which was one of the main reasons why I carried the bill, one lady was in an abusive marriage for so many years. She finally divorces her husband, and she's out there. She says, I'm going to be an insurance agent. So she goes to school, passes all the insurance tests, and then when it came time to get licensed, our state denied her because she had bad credit. So this is so incestuous, and so it can really impact your life in so great ways, in so many ways that we don't even think about. And, medical debt is something that we really need to get an arm around. It should not impact you. One reason why I was inspired to carry the bill, I'm a mortgage broker, and I see that the FHA does not count medical debt against you when they are looking at your credit history or for buying a house. So if the federal government was able to eliminate medical debt, it made sense that we should not score it in the credit score as far as your credit profile. Does not mean that you don't owe the debt. You do owe that debt because you incurred the service, you received the service. However, it should not be a noose around your neck forever. We got a lot of pushback, of course, from the financial agencies, banks. Oh, wow, Rep. Ricks, we didn't expect you to carry this kind of a bill. You're going to impact us. The sky's going to fall in. But, it just says that, somebody's debt is someone's profit. So there's so many different sides of everything. One person's being impacted, but they feel like you're taking bread off their table. And so there's a lot of pushback and push and pull around it. But I would say that, we've seen upwards of 80 points increases in people's credit profiles by removing the medical debt off your credit. So it's a really great bill, and I know that we still have yet more work to do when it comes to policy and legislation in this space.
Thank you. And Jared, I heard about you because you wrote a paper for Health Affairs and looking at some data from your organization. Tell us a little bit about how this came into being and what you all do.
Yeah, thank you. So I started a nonprofit called Dollar for Portland. I grew up in Portland, Oregon, and it was because I watched my own family go through a medical crisis. So my wife and I were sitting at home. She got a phone call. Her aunt had passed away from cancer. A couple minutes later, I got a phone call. My cousin went into labor 7 weeks premature. Baby needed a heart surgery to live. And the big conversation was, how are we going to pay for it? So I was really frustrated that is the reality for a lot of Americans. When you have a medical emergency, you have a financial emergency. So I started crowdfunding in Portland to help people pay medical bills. I did that for years, and then I found out about something called hospital financial assistance, hospital charity care. So most hospitals in America are nonprofit, they're tax exempt, they're required to offer free or reduced care, so they will waive or reduce your hospital bills if you meet certain income guidelines. They just don't tell you about it usually. So when I found out about this, I realized I had been paying medical bills for families that all would have been eligible for these programs. So I was frustrated yet again. And so I started helping people access these programs. I started diving into these policies, looking at the applications, and just realizing how hard it is to apply for these programs. And patients leave the hospital without any knowledge of these programs. Most patients are going on payment plans, declaring bankruptcy for bills that they don't have to pay if they knew about these. So in a few months, I got over $1 million in medical debt to be cleared for people just by filling out paperwork and helping them, through the financial assistance process. So I realized, okay, this is a big problem. Nobody knows about it. Try to get the word out. So in 2021, I jumped on TikTok and started making TikTok videos about charity care. They went viral, and our organization exploded. So since 2021 till now, we've been able to relieve a little under $100 million in medical debt for people throughout the country just by making charity care known and easy for patients.
So I wasn't sure I was going to tell this story, but I will. I, like everyone else in the room, probably was a victim of some cyber attack at some point, and so I got free credit monitoring. That's what they always give you. And a few years ago, I got an email that my credit score had dropped by 120 points. And I looked into it, and it turned out I had a collection agency had put in a credit report against me for a bill that I didn't even know existed. And once I traced it down, I could figure out they just had my address wrong. They didn't try very hard to find me. But once I sorted it out, I was able to clear it up. I also knew that I had to actively ask them to take it off my credit report, which is something they're required to do, but they don't tell you that they can do that. So there, Manasa, you mentioned a little bit the number of players. Can we go a little deeper into how opaque this system is? Because I think a lot of people think you go to the hospital, you get a hospital bill, you don't pay it. Yes, maybe they come sue you, maybe it goes to collections. But there are a lot of players here, and I think that's part of the resistance that you mentioned, Niqueta, about when you try to address this legislatively.
Yeah, so I touched on this a little bit in my earlier answer, but so yes, you owe the hospital bill, and then several entities come into play, as I mentioned, the revenue cycle companies, if they use or contract with a debt collector, or sometimes even collections litigation firms, like they all can collect on behalf of the hospital, and then sometimes the hospital will sell the debt, as I mentioned, to third-party debt buyers, and they can kind of initiate this activity as well. The patients, a lot of, whenever we talk about these kinds of issues, there's a lot of focus on educating patients. Like, let's notify patients. Let's give them even more information. Okay, these are people who are going through medical emergencies and issues in hospitals, and they have a lot of factors that they're considering in the moment. So the focus of, yes, we should post a notice in the hospital ER waiting room about financial assistance. Yes, sure, absolutely. Yes, you should include documentation in the bills that people send. Yes, absolutely. But I think the focus of better policymaking would be to kind of remove the onus from the patients in the first place, especially as they're undergoing a very stressful period in their life, and putting it somewhere else, which is in the hands of hospitals, to potentially maybe do presumptive eligibility screening, which is something a couple of states have started doing, and finding ways where you can proactively protect the patient, where they don't have to sit there and educate themselves about all of their rights, like removing, that you can get that information removed. You have to learn about it and then file, 20 more pieces of paperwork before it happens? This is just not a sustainable situation. And so I think that takes me back to, what kind of drives medical debt in the first place. And Alan mentioned, of course, cost sharing, huge problem. We all know this. Deductibles are rising. The cost sharing is rising. Premiums are rising as well. So there's just a lot of financial exposure in the first place because of insurance coverage and the way it's been declining in terms of how affordable it is and how much it covers. But I mean, this is not coming from some vacuum, right? This is like being driven by healthcare prices. I mean, you ask insurers why this is happening, they'll tell you, hospital prices are going up, what else are we supposed to do? And you could ask, hey, insurers, why are you not then negotiating better prices for us? Isn't this a market where you're competing against one another and shouldn't you be giving us a better product? And the answer to that is, well, if every insurer is facing all these rising prices and everyone's raising their insurance costs, what is the competition there? There is not really a market where you're competing. So there's not really much incentive. I mean, employers are now getting into the game of trying to push back against insurers, give us a better deal for the dollar and all of this stuff. But it's this is all in the nascent stages. And then you've got healthcare prices. What's really driving them? They'll tell you costs. Costs are what's driving them. Do we know what those costs are? No, we don't know what those costs are. We have Medicare cost reports, and they do give you a slice of the information, but it's sort of like piecing together the full picture by looking at shadows, right? It's very kind of disparate information. It's like a cake that you have a general sense of what ingredients are in there. You have absolutely no sense of the full list. And today, we just don't know what it takes to run a hospital in America. There's just not a good basis of information to tell you what it takes to provide a healthcare service. So really, it's just a much more deep problem, and the medical debt piece of it is not some unexpected side effect. It's clearly the predictable outcome of what is going on the front end.
Well, so I think if we think the solution to the medical debt problem is containing healthcare costs, we are going to be having this session every year for decades, right? And so I think you're right. As much as that's the first stage of the problem, the second stage is really the structure, right? So it's not just that it costs a lot, it's that we put a lot of costs on people at exactly a time when they're in stress. Mm-hmm. So I wonder, Nikita, if you could talk a little bit about sort of the legislative response. You mentioned some of that, but sort of how do we shift the onus to those who have the resources to deal with it as opposed to your constituents who are struggling?
And so when we look at medical debt and how much people pay for the costs, again, costs are always rising. We have inflation, no inflation, and the U.S. has the highest cost for medical care when we look at it. But I think there's some things that we can do as a state. For example, the ACA did help to try to include lots of care as preventative care. So a lot of people who are healthy, first of all, would say, I don't need a very expensive plan. I'm very healthy, but then emergencies can happen, right? So if you're able to standardize the plans so that a lot of things is considered preventative care that can kick in before a deductible kicks in, clearly that's a way. California is a place where I think they have all standardized care plans. And I would love to know how they did that because that would be great to do in Colorado. However, again, it's not going to be easy, right? Because people are looking at their profitability and they want to make sure that they're getting the most bang for their buck when it comes to providing this health care. So that's one place. Another place where you could look at is the regulation of these debt collectors. There's third parties that are not very well regulated within the state, or there's some regulation. They're aggressive. They can take you to court. They can force people into bankruptcy or get garnishments. So we want to look at what practices they're operating under in Colorado and see if we can rein that in as well. And then just looking at equity. We know that medical debt really impacts low-income people, minorities, single women, and families, and mainly because the plans that they might be in are not effective. They don't provide the proper amount of coverage that they need in order to get the best health care. And then we've also heard about Medicaid. Oh, everybody should go something Medicaid, but I think last night when we listened to Nancy Pelosi talk about the ACA, the Medicaid plans are not maybe the best. They offer a minimal amount of care, but I don't think that's going to be the best care for everyone. So there's so many pieces that you really need to put together and kind of bring everyone to the table so that you're able to give people the best value for their buck when they're getting insurance, because just having insurance is not enough. We know that there's always gaps, and we want to make sure that people are getting the care that they really need when they need it. So.
And I just want to emphasize the push to including things as preventive services, which then under the Affordable Care Act, at least as the law stands now, would be provided without cost sharing. It's just a reminder that so many people are living paycheck to paycheck that it's not just a hospitalization that can lead to medical debt. An expensive lab test or an office visit, an outpatient service can do it as well. And then you get into this cascading where the arrearages build and the penalties build. So this is not just a hospital phenomenon, although the big dollars are there. But that takes me, Jared, to you. It's been a few years since we spoke, but I know at the time you were really thinking about, again, how do you take the onus off the patient? So part of it is awareness, as you said, people don't know about this. But is there more that could be expected of the places that people get care so that it's not just education and action at the time when you're dealing with a health crisis?
Oh man, yeah. I'm trying to not get too into the weeds here, but it's
the weeds are important.
Oh, yeah,
Don't worry.
I feel like we have the hospitals, the insurance companies, they are holding all of the power, and we just have an incredibly inequitable healthcare system, and it is built for people that have time. Tools like how much time did it take you to get that, credit score right? It is a part-time job to figure out how much do I owe, who do I owe. There's so many different things. So, and we see this impact, Black and brown Americans, rural communities, much more. And at $4, we see these communities have more medical debt. They are much more likely to apply for a program like financial assistance because they need it, yet they're more likely to be denied by those providers. So I think that what we are trying to do is we're trying to get hospitals to be required to screen patients for financial assistance before they can send the bill. And it's not so much a, hey, this thing exists. You can go, because right now the law says it has to be widely publicized and widely available. So we have a poster in the ER is widely publicized, it's widely available, right? So that doesn't work. Patients aren't finding those. So what we're trying to do is have patients, they're not even able to leave the hospital without knowing, hey, you're eligible for a 75% discount, and here's how you can apply. Or, like you said, presumptive eligibility tools that they wouldn't even have to fill out the paperwork. It would just have them apply. So, yeah, we are trying to shift the burden of financial assistance from the patient, because it is all on the patient right now, to find out, to navigate, to fight for it, to the hospital to be required to do that.
So I'm just going to stick with you for another minute, because one of the things I remember from our discussion some time ago is, the hospital is required to have a policy, but 3 different hospitals in a community have 3 different policies, and they have different dimensions. There's income, but there may be assets or the size of the bill, and proving that you're a resident, and that also adds complexity. Can you just say a little more about how we could maybe address that?
Yeah, so we've got about 8,000 hospitals in our database. Almost every hospital in the country, all their charity care policy data and their application, so what they ask. And it's wild, people. They're not the same. And we have seen questions like, how much livestock do you own? What is the make, model, and year of your car? Have you started a GoFundMe, and how much have you raised? We need to cut out the things that should not be factored in at all. And hospitals will say, oh, we would never expect a patient to cash out their retirement or sell their home to pay a medical bill. It's well, then why are you asking about how, right? So, and what that does is that puts a tremendous amount of distrust in the patient, because it's okay, wait, I'm not about to give you that personal information because then you're going to take it from me if I have it, right? So and we can talk about the distrust, but it's yeah, they're all different. Nothing is standardized, and I think that like the income thresholds make sense that it would be different. Like you should be able to make more in New York and San Francisco than in rural Alabama or whatever. But whether or not they can ask about your car or your retirement or all of that, we need like a standardized application that is like, hey, you can ask these things and not these. Asset tests and all that are no good.
And I'll just jump in for a
please.
quick second. So states are kind of doing this, and Colorado does this, where they do set some minimum standards for these financial assistance eligibility policies, and also in terms of the application process. There are some states that require that all hospitals use like a uniform application form and limit what kind of assets or income type information you're asking, what kind of paperwork are you requiring. And so some states are kind of jumping into the fray here, but it's fewer than half. So it's not a huge number of states that are doing this, and I think that has been helpful. But as Jared was saying, you'll still see a wide variation. And I think one of the more interesting pieces that's been coming out of the research is that you would expect that nonprofit hospitals would be doing a better job than for-profit hospitals at providing charity care, but several pieces of recent research has shown that is not the case. If anything, sometimes they're even more aggressive in terms of collecting this. So really, what gives, I guess, is the question that we've been trying to unpack for a while now. And people will say, oh, it's because IRS does not require them or monitor the paperwork they're submitting. But that's just that they're not being watched, but there has to be a driver there. Something is driving there. And there's a lot of complex issues around debt financing and how all of that works that I will not get into right now. But that is another piece of the puzzle that we've been trying to understand. What is going on with nonprofit hospitals, and why are they such a big piece of this problem?
So before I turn to you all, I do want to, I want us to have a discussion here about the solution set, which we've started to describe here. This is a horrible problem when you're on the receiving end of it. And the layers of the origins of the problem are many layered, right? That we have an expensive system, that we have a lot of cost sharing, that we have an inequitable country. And I'd love for us to solve at the very root, but those are long-standing problems that are going to have a long time for us to address. So I'd like us to sort of start working up, and each of you have started to do that. Just help our audience understand some of the approaches. One thing there was a quick reference to purchasing debt. It's actually fairly cheap. There's some shame. There's a role that shame is played here because a lot of this is done without the hospital's name, and then when the community finds out, they get up in arms. So let's just build out some of the solution space, if we could, at all of those levels, and then I'll turn to the room to see what kinds of questions they have.
I mean, I would jump in and say that we're just talking about Colorado. Talking about using third-party debt collectors. Nonprofit hospitals will hide behind these non-parties. They don't want their names out there that, hey, it's actually a university hospital that's collecting. They want this third-party debt. So I think we took away and added more transparency within this whole debt collection piece recently. And we're constantly going after them because they are making a lot of profits that should be now translate into being poured back into the communities, and you're not seeing that. And they're aggressively fighting to secure their turf, don't come after us, and oh my goodness, where healthcare is so expensive, and we're doing the best we can, and we're really doing a lot of community sharing. So, but I do think that there's more to do. I especially, like I mentioned about the standardized plans, I think that's an area where there's opportunity if you can get more standardized plans. I will be trying to research and see what California has done in that space and how they were able to get more people to the table, because that makes more sense. If you're going to have healthcare, let it do something for you, not just put money in the insurance company, and then when you really need it, you have to kick in with $8,000 in order to use your plan. So I think that's an area that could really help people, that is useful for them.
Other thoughts, other solutions that you're hearing about that are worth exploring?
Yeah, so we, funded by Commonwealth Fund, I guess, Shout out to our funders. So we publish a 50-state map and report on the various sort of bundle of protections that states can enact to help people from accruing medical debt on the one hand, and then kind of protecting them once they've accrued it. So of course, financial assistance, we've spoken about it, setting eligibility levels. Also key, setting how much they should be eligible for and limiting what charges are being, if you say 70% of what? So kind of like specifying that denominator, I think is also super important. And kind of, and then making the pathway to getting financial access as we spoke, financial assistance as we spoke about, kind of clearing those hurdles. That's key. There's also community benefits, which is kind of like a little bit more nebulous. This is sort of a quid pro quo. Nonprofit hospitals, you're getting all of this tax-exempt dollars they get to keep. You need to provide benefits to the community. Community benefits can include financial assistance, but it can also include other kinds of things like vaccine drives or workforce development and a lot of other things. Do we want this pot of money to be focused entirely in financial assistance? Yes and no. We kind of want them to invest in other ways too. So that it's kind of in the play, but it's kind of questionable how much we want to kind of, want to turn all of that money just towards provision of charity care. And also, it is not really well monitored at the IRS level. I mean, they're not really there's no minimum requirement. Some states like Illinois and Utah and stuff have like a minimum amount of say operating revenue or something that hospitals have to expend on community benefits. But I think what's kind of more interesting and fun, I think, is what Pennsylvania does, which is it gives the taxing districts lawsuit authority, so they can go sue a hospital and say, hey, you're not spending on community benefits, which I think is very creative and creates for and I would love for somebody to do this study, or fund me to do this study, to find out if that has actually resulted in maybe lesser amounts of medical debt in Pennsylvania as opposed to other places. So community benefit, those are the two things that sort of are in the policy space for avoiding the accrual of medical debt. And then downstream, of course, it is limiting interest rates that you can put on medical bills. There is requiring hospitals to offer payment plans and kind of capping the monthly payment rates and the interest rates on those. And Colorado does something really cool where it's like after you make 36 payments, the debt is considered fulfilled. It doesn't matter. You pay 5% or whatever of your income for 36 payments, and then that's about it. That's the maximum that you can be asked to pay. So that's like a great way to kind of cap people's financial exposure. Then you can require hospitals to oversee all of these entities and make them financially responsible for what they're doing. And then there's placing caps on, or so limiting what you can get through lawsuits. There's states that now ban wage garnishment for medical debt actions. There's states that ban seeking liens and foreclosures on unpaid medical debt. That's another thing. And this is going to sound really wonky, but just hold out for a second here. Data, it's important. Okay, it's really hard, and it's not sexy. Nobody wants to talk about it, but it's important. We just don't know. The data is just not out there. It's a very few states require granular reporting in terms of how much financial assistance is being provided to whom, what are their racial, ethnic, zip code breakdown of the people that you're giving financial assistance to. Whom are you suing? How many times are you suing? We don't know. We don't ask the hospitals to report this information in the majority of states. So really, there's no one to mind the shop. I mean, yeah, you can have requirements, but there's not really a build out of the oversight and enforcement side, which is another big place where I think states are still kind of trying to figure out how to make these, consumer protections actually work in real life.
Oh man, you just covered a lot of them. I would say, the medical debt off credit reports is something I don't think has been mentioned. I think that's pretty key. Having something that is supposed to be an indicator of your financial responsibility and whether or not you got cancer or got sick and had an emergency, I don't think that should be a factor at all. So I think that's a big one. I think I'll go back to the presumptive eligibility. So a lot of these hospitals have presumptive eligibility tools where they will use data to, and it's a lot of credit data and whatever, where they'll see, okay, we think that these people are likely to be eligible for financial assistance. What we found is most hospitals are running that the day before they send it to collections, and we're trying to get it earlier, right? And I think that makes a big difference. So we got this law passed in Oregon that requires hospitals to screen before billing, and one of the hospital, they just had their board meeting, and they said before the law, we were basically telling patients about our charity care program when we were asked about it. and that resulted in about 12% of patients receiving some sort of financial assistance. After the law, that number has gone up to 64% of patients receiving some type of financial assistance, which will put $30 to $50 million back into the pockets of low-income Oregonians every year. And it's like, it's pretty easy. Just tell people about your program. So that's all I got.
I'm curious, Nikreta, you mentioned the pushback. Mm-hmm. This is also a national movement. There are lots of states, many aren't, but there are many that are working in this area. This may sound a silly question, but I just have to ask, like, did the pushback worry you or did it motivate you to go farther with this? And just since I'm going to ask you a question, I'm also really curious what kinds of conversations you have with colleagues from other states, because I'm sure they're facing similar challenges.
Yeah. And so, no, the pushback, I think, like you said, really gave me more passion because I understood. I mean, the banks were like, our business is going to fall in. Now we don't know how much debt exposure they have. And oh my God, we can't believe, so it was all of this. But I'm a mortgage broker. Again, I understand. And I felt like if the federal government didn't think this was important, then why should you think this is the biggest deal? We also know that that would just create a cottage industry where somebody else will be presenting that medical debt somewhere else. It just won't be on the credit report and it won't be scored in your FICO. So that was important. And as far as other people calling, the CFPB was going to use the bill that we passed in 2023 in Colorado as the model when they were setting their rules and regulations. But things have shifted since we had a new change in administrations. But that was what they were going to use as the model to ensure that people's medical debts are not counted against them. So it's a really great piece of policy because I don't think that the banks didn't go out of business. They're still around. But of course, people are going to push back. But I have heard some really great ideas here around the data and trying to gather that. And then, the upfront evaluation as to when do you screen them? I don't think that's been done in Colorado, so maybe, who knows? That could be some policy that we run in 2026. Yeah.
Great. Mm-hmm. We have time for your questions. We do ask that you wait for a microphone and tell us your name, and please, in the back, and then we'll come up to the front.
Hi, my name is Mary. Thank you for the session. I am a trustee with the Health Foundation, and I've always worked in hospitals, and I just want to say I adore them. Thank you for saving all the lives. And on the topic of nonprofit hospitals, I feel like there is data available for analysis that has not really been considered. So in my space as a trustee of a health foundation, we often see nonprofit hospitals seeking grant funding to stand up programs. Concurrently, they are now on the community benefits side developing their own grant giving programs to capture that PR opportunity. Has anybody ever stepped back to look at the total amount of community impact dollars hospitals are required in the nonprofit setting to give out? What total percentage of that is given to charity care compared to their total percentage of bad debt write-off?
Good question. Now I'm trying to run through the list of studies that I've looked at. To that point specifically, I don't recall something having been done yet, but that is an excellent flag. And I think I've heard of people trying to get into, so nonprofit hospitals are eligible for bond financing through the MSRB, and they get tax exempt, bond financing. And so that is, and they do have to submit a lot of financial disclosure information. And that is something that, is something that we're hoping to get into and try to unpack a little bit more. But in terms of what percentage of what is the total community benefit spend, what portions are going to, what kinds of community benefit activities. The 990H form, which is the IRS form, does have this information. Is it very granular? Is the methodology defined? Are they even filling? I mean, I know that there's been researchers that I've spoken to where they're like, hey, a lot of them kind of fill it out, and then some of the information is just blank. Mm-hmm. And so it's kind of like, yes, the form exists. But if you don't define the various components in granular detail, should you be allowed to calculate, include Medicaid and Medicare shortfall as part of community benefit? Like, that's a big question. We don't know. Like, I think they do include them, a lot of them. But is that the right policy, that we want to be pushing for?
In conclusion, as everybody is consolidating into a systems level approach, right? Like more and more hospitals are just a part of a big system. They only fill out one of those forms.
Right.
So you cannot understand at the community level what the impact actually is.
Yeah.
Please, thank you.
So I think there are researchers who focus on the 990 data, and they are very limited. And this question, I'm glad you brought it up. I personally think counting underpayment of certain payers I actually kind of think it's a joke, but it's also completely different than this kind of community benefit. So I think we have a long way to go on the data, but I appreciate that there are people who are looking at it. We had a question up here.
My name's Marie Hastings Tolzman. I worked for many years at the University of Colorado Anschutz campus, and I'm now in Texas. And this whole thing of payment and reimbursement is really interesting to me. One of the, I think, is a little bit dangerous assumptions that's been made here is that everybody wants to pay their medical bills in some fashion. And there are the cancer, the preterm birth, the NICU babies, the whatever, where the costs are outrageous. But there are also a lot of people on the other end who don't want to pay any medical bills at all and want a lot of services. So that's a worrisome thing for me, the whole piece about taking responsibility for your lifestyle choices, smoking, drinking, weight, all that, is not even factored in. The second piece I wanted to raise was I haven't heard anybody at the conference yet mention new models. And so it's like we keep chasing the same old in terms of compensation and reimbursement. So for example, in the 60s and 70s, there was a nurse researcher out of the University of Minnesota, Ida Martinson, who did a lot of work about block nursing. Cuba, South Africa sends their medical students to Cuba to learn how physicians take care of a so many mile area to have improved health outcomes. And they reimburse based on the health of those blocks or whatever. And I haven't heard anything. And you look at CMS and they reimburse providers differently. So people who may do very well with a nurse practitioner or PA or whatever get reimbursed for some services less than if you're a physician. So I'm like, the system is so screwed up, and I don't hear talk about new models. So I'm wondering if you might comment on that.
Reactions to either half of that. I will say at the opening session, we did hear Atul Gawande mention community-based primary care without a financial transaction between patient. So it has at least come up in that session, but
I don't know. Definitely don't have an answer. I would say what I feel is that people are so terrified of anything new that we are stuck trying to make the old things better or the laws that currently exist actually be enforced, because if we try to bring up anything too radical, then it's like laughed off. So I think that would be that's my instant reaction. I don't know if I'll address the first part, but yeah, go for it.
I mean, I would say that we've talked about universal health care, and that's always like a big, like, oh my gosh, socialist medicine and all of these things. You get an immediate visceral reaction. So I'm not sure what the tolerance is, for us to pass that. It's been explored here several times in Colorado, and as soon as people say anything like that, there's an immediate pushback. But we know that we can do healthcare better. When do we get to a place where we're able to pass something and then change everything to implement that type of a policy? It might take some time. I don't know how long, but there's conversations around it, but we don't have the votes to pass it. So that's kind of where we're kind of stuck. Yeah.
Access, you're absolutely right in the sense that there's a lot of focus on access to coverage, which is important, but I guess the connection between coverage to care is like something that is, I think we're still trying to, build that bridge. And, are we paying for value? For value-based payment, of course, has obviously been around. People are talking about it, but then given the fragmented nature of payers and adoption across the board. We have not necessarily seen the level of adoption and like the improvement in patient population level outcomes that we would want. That said, I think there are a lot of new models, and this is actually an unrelated topic that I also research inside, is to look into a lot of non-traditional and innovative healthcare delivery models, whether it's mobile health or to what degree, telehealth or digital apps or whatever can really kind of get into this. What kind of workforce development programs do we need to kind of get more people from the ground? What kind of scope of practice expansions do we need to kind of get more, workforce into the field? And I think that's an area that, I think it's just kind of like a continuum. You need this and that. So those are long-term changes, and there are a lot of healthcare services researchers who are focused on that work, and they are trying to build out. When it comes to innovative models, I think there's a lot of, you test, there are a lot of them are developed from top to bottom. They're developed at an academic center, they're developed at CMS, and then they're kind of deployed into the field. Then a state Medicaid agency might choose to say, okay, we're going to reimburse it in this way. But then it becomes a question of the toggling between fidelity and flexibility, right? Because if you have only tested this model for this specific population in very specific parameters, and you need 15 providers to make this model work, and that is the only evidence that's been established, then the state Medicaid agency is then going to only reimburse for that specific model. So you don't see the scaling becomes kind of hard. So it's a hard job that we're put in the hands of policymakers to some degree, where they have to kind of decide, looking at the evidence, how much flexibility do we have here? How many more people do we want to target with this kind of emerging model that seems promising? It's kind of a complex issue, which I know.
So I know I'm not a panelist, but I actually think your first question is the answer to your second question, and they need to be tied together. We've made a societal decision that personal financial responsibility for health is skin in the game and is something that is viewed as important. That, by definition, creates debt for those who don't pay it. We could, as a society, decide that we wanted not to have such high cost sharing, but that would then go against the first half of your question. So I actually think the two sides are related. We have time for one more quick question and quick answers.
Hello, my name is Sophia, and I wanted to understand with this charity care and all these funding sources that they have, do hospitals have an incentive to not make patients aware of that? What happens if it's underutilized? Where does that additional money go?
It's a great question.
So I have talked to a lot of hospital CFOs. I've gotten a lot of different answers. Sometimes it is, hey, this is just a perception issue. We don't want to look like the most generous hospital because we don't want all the poor people coming to us. So there's that. There is also, this is really, really hard. It's really, really hard. It's a huge administrative burden to screen everybody and to make sure, and we already do it. We already do it so well. So there's and there's that argument. What we've seen is and this goes back to that Schedule H question, is there, on the 990 Schedule H, it asks, how much bad debt did you have? So they'll put that. And then the next question is, of that bad debt, how much do you think was eligible for charity care? Most of the time they leave it blank or put 0, which is not true, right? They did not do that perfectly. So again, back to the data, it's really, really hard to know because we don't have reliable data on that. So I think that it is more so in just this is what you do. You put a patient through the collection process, and that's just how it works. And if a revenue cycle department at a hospital is going to invest in making something better, it's going to be in how to drive more profits, not to how to better their charity care program. So it is just another very low priority is what we hear.
So is it fair to assume that any underutilized charity care becomes profit?
I think that no. So because it's not, I think a lot of times people think charity care is this pile of money that kind of runs dry. It's just what they're required to do in exchange for their tax exempt status. And right now, what we see is at a very, very low estimate, hospitals are failing to distribute about $14 billion every year in charity care that should be given out. So, but it's not now they're profiting $14 billion extra. It's just that, and the collection rates on they're trying to bill people that can't pay. They're not, even if they send them through the collection process, they're not getting a whole bunch of money out of that. So sometimes we even have an argument of like, you're actually spending more money trying to collect from patients that can't pay than you would if you were to just identify who's eligible earlier on.
Well, I hate to cut this off, but I'm watching the clock. That's my job as the moderator. Please join me in thanking these terrific panelists.